Hello and a very warm welcome to this presentation on the Deaf Scotland report, Deafness and Dementia, Predicting the Future for Scotland. This publication is the outcome of research carried out in partnership with Queen Margaret University, and it was funded by the Life Changes Trust. The presentation today will take two parts. In the first part, I will explain how the project idea came about and the background to it. I will then summarise the format of the project and how the methodology was applied. The second part of the presentation today will look at findings and their implications for the future. But first, to set the scene. There is a known association between hearing loss and dementia, and it is thought that untreated hearing loss may be a risk factor for cognitive decline. In 2017, the Lancet Commission concluded that 35% of dementia could be prevented by modifying 9 risk factors. Midlife hearing loss was one of those factors, and as such, hearing loss is now considered to be a potentially modifiable risk factor for dementia. While the link between hearing loss and dementia has been firmly established, and an increasing amount of research on the topic has been done, there has been a noticeable gap in studies that were specific to the situation in Scotland. This research project then aimed to address this gap by undertaking a scoping exercise to establish prevalence rates and an evaluation of current service provision for those with hearing loss and dementia in Scotland. This presentation will be in two parts today. In this first part, we will be dealing with the background to the research, the Lancet Commission, numbers of deaf people in Scotland, the format of the research, and data sources. Firstly, the Lancet Commission. In 2017, the Lancet Commission on Dementia Prevention, Intervention and Care concluded that 35% of dementia could potentially be prevented by modifying 9 risk factors. These risk factors were low education, midlife hearing loss, obesity, hypertension, late life depression, smoking, physical inactivity, diabetes and social isolation. The 3 most common potentially modifiable risk factors for Commission were identified as being poor early school education, midlife hearing loss and smoking. The Lancet Commission stated, acting now on dementia prevention, intervention and care will vastly improve living and dying for individuals with dementia and their families, and in doing so will transform the future of society. Since the findings of the 2017 report, hearing loss has been considered to be a potentially modifiable risk factor for dementia. On the 30th of July 2020, the Lancet Commission published a report that updated the 2017 findings and included a further 3 additional potentially modifiable risk factors for dementia. These factors are excessive alcohol consumption, head injury, and air pollution. In the Dementia Prevention, Intervention and Care 2020 report, it suggested that the now 12 potentially modifiable risk factors should be further researched. In terms of midlife hearing loss, the Commission suggests 1. Encouraging the use of hearing aids for hearing loss, and 2. Reducing hearing loss by protection of ears from excessive noise exposure. These findings will no doubt continue to stimulate debate and encourage further research. Moving on to the inspiration for the project. Deaf Scotland wanted to add to the hearing loss and dementia evidence base and had been discussing ideas with research with Queen Margaret University. The initial idea for the eventual project was found in a 2015 study carried out in Germany. In this particular study, Typo and his team looked at the insurance claims data of the largest public health insurance company in Germany. Using this data, it was possible to carry out analysis on the association between regional prevalence of dementia and hearing impairment. The results confirmed that the relationship between hearing loss and dementia also existed at a regional level. These findings served to emphasise the role of hearing impairment as a risk factor for dementia and were thought to be relevant for planning the service provision necessary at both regional and national level. How far could this type of study be applied to the situation in Scotland? Was it possible to obtain regional prevalence rates for hearing loss and dementia here? We decided to find out. The 4 pillars of deafness model. To ensure that the whole spectrum of deafness is included and to emphasise the diversity required in terms of services needed for those with hearing loss and dementia, this project adhered to the 4 pillars of deafness model. The 4 pillars are deaf, people who are deaf-blind, deafened, and hard of hearing. Now, in terms of how many people have hearing loss in Scotland, it's widely known that the exact numbers of people with hearing loss in Scotland vary depending upon which source is consulted. Now, this lack of clarity is obviously problematic when it comes to planning for the delivery of future services, and it's widely recognised that there is a need to establish better reporting procedures in order to capture relevant statistics. So, moving on to the research methodology of the project. As I said, this research study is a partnership between Deaf Scotland and Queen Margaret University, and it's been funded by the Life Changes Trust. The research proposal was approved by the Queen Margaret University Ethics Committee prior to the start of the project. The methodology used. This research was a mixed method study using qualitative and quantitative data. A full literature review was carried out, and then the project was split into 2 parts. In the first part, the intention was to undertake a search for sources which provide statistics on deafness and dementia. From these figures, baseline numbers for each of the 32 local authorities in Scotland would be calculated. Then, using population statistics from the National Records Office, these numbers would be projected to give future estimates. Part 2 of the project involved a focus group of audiologists in Scotland. Participants in this group would be asked to give opinion on the current service provision available for those with hearing loss and dementia. Moving on now to the gathering dementia prevalence figures. Following discussion with members of the audiology profession, it was confirmed that at present there is no uniform standardised method to record whether a patient has dementia. In relation to recording data in audiology services, it was pointed out that while it would of course be possible to include some sort of note in the patient record, there is no dedicated marker field to enable this, and as a consequence, it would not be a searchable criteria in terms of data collection. It was suggested that markers relating to deafness and dementia might well be noted in individual patient records at GP level, and this may be a way of collecting prevalence figures. However, it was pointed out that as there is no uniform process for this, it would be at the discretion of practices to carry out such a procedure, and so if any data was available from this type of route, it was not likely to provide a national picture. Subsequently, it was suggested that it might be possible to gain an overview of GP data by making a research request to the Scottish Primary Care Information Resource, SPIRE. This suggestion was taken and a request was made. Moving on to the Scottish Primary Care Information Service, SPIRE. This was launched in May 2017, and the aim of SPIRE is to provide a single national system to extract data from general practice clinical IT systems in Scotland. An information request to SPIRE was submitted, asking for the type of data they currently had in hearing loss and dementia prevalence rates in Scotland. SPIRE was able to provide dementia prevalence figures for Scotland for a 3-year period, April 2016 to April 2019. These figures were broken down into local authority areas, but it was not possible to break them down into either gender or age categories. However, the SPIRE database does not include any hearing loss figures, as it is not collected at GP level. Next, Alzheimer Scotland. In addition to the dementia rates provided by SPIRE, Alzheimer Scotland statistics were obtained. Alzheimer Scotland state that there are an estimated 90,000 people with dementia in Scotland. Around 3,000 of these people will be under the age of 65 years. This estimate is based on the results of slide studies that screen for cognitive problems and dementia within the population of a set geographical area. There have been no such studies in Scotland, so we rely on the best available evidence from Europe. Upon request, prevalence rates for 2019 were provided. These figures were broken down into age, gender and local authority area. Hearing loss prevalence rate figures. The problematic nature of gaining numbers for the prevalence of hearing loss is widely known. As stated, it was not possible to obtain prevalence rates from SPIRE. In order to give as accurate a picture of the numbers as possible, the number of people with hearing loss in Scotland, the Davis model was used. Although published in 1995, Adrian Davis's comprehensive study on the prevalence of deafness in the UK population is still the benchmark for statistics in this field. David established percentages of prevalence for predefined age groups. This work was refined in 2014 when Ackroyd used 2011 census data, applied the prevalence rate criteria that Davis had set out in 1995 and calculated estimated hearing loss for the UK population. Estimating prevalence for deafness and dementia. The prevalence rates for deafness and dementia were calculated using both the data obtained from SPIRE and Alzheimer Scotland. In both cases, the estimates from the Davis model were used in the absence of actual hearing loss prevalence data. Projections were created by applying 2016 base population predictions from the National Records Office to the prevalence rates for the dementia and hearing loss which were obtained using the Davis model. Once the prevalence rates for hearing loss and dementia were estimated, they were projected over a 20-year period in order to establish the overall trend for 32 councils in Scotland. In terms of the qualitative part of the study, this focused on a discussion group. As stated, this part of the research took the form of a discussion group. Participants for the group were recruited from the audiology profession, and discussion was centred around findings of stage 1 of perceived gaps in the current provision and suggestions for information gathering strategies for the future. That brings us to the end of part 1. Join us in part 2 to find out what all this data tells us. Welcome back to part 2. In this part of the presentation, we'll be dealing with the data from SPIRE, what it tells us, the data from Alzheimer Scotland, a comparison of the two data sources, the discussion group, and generally findings, what comes next. Firstly, dealing with the analysis of the data from SPIRE. There were issues to consider in terms of the SPIRE data. The data firstly is obtained from individual GP practices in Scotland. However, the quality and outcomes framework indicates that some practices have not actually returned data. This means that populations and registers for clusters, health and social care partnerships, local authorities and health boards are likely to be smaller than the reality. Also, as a means of ensuring patient confidentiality, GP practices do not detail values where there are less than 5 in a particular field. Again, this will result in lesser numbers. It's known that there are significant underreporting of dementia cases generally. Another issue to consider is that local authorities with fewer GP practices could be subject to higher variability due to the smaller sample size. These are issues to take into account with SPIRE data. Moving on now to Alzheimer Scotland. Alzheimer Scotland dementia numbers have been produced by taking population numbers from the National Records Office of Scotland and multiplying these with the European Collaboration on Dementia Eurocode prevalence rates for each age group. In terms of a comparison of data of the two sources, prevalence rates calculated using data obtained from SPIRE differ substantially from the rates calculated using Alzheimer Scotland figures. This can be seen clearly in this table. Estimating prevalence rates. The data obtained from Alzheimer Scotland was seen as the most robust, and it was used to define the prevalence rate estimates and future projections. Moving on to estimating future numbers. Once current prevalence rates were obtained, it was possible to predict future prevalence. These projections were accomplished by applying 2016 base population predictions from the National Records Office to the prevalence rates for dementia and hearing loss, which were calculated using the Davis model. The figures were then projected over a 20-year period in order to establish the overall trend for all 32 councils in Scotland. Moving on now to the qualitative part of the project, the discussion group. We'll deal firstly with the format. On the day of the meeting, participants were given a brief overview of the content and purpose of the research. They were informed that while the overall aim was to establish prevalence rates for hearing loss and dementia and project these figures into the future, there was an additional project aim. That aim being to establish perception of current service provision for those with hearing loss and dementia. Rather than a structured question, a broad theme was put to the participants to encourage discussion. The participants were asked about their opinion and the level of service for those with dementia and hearing loss in Scotland at this time. They were also encouraged to suggest ideas for improvement. This was to allow as wide a discussion as possible around the topic. Participants were assured confidentiality was guaranteed and all responses would be anonymised. Summary of the discussion points of the group. The main points were sorted into themes and are listed below. These themes were referral of patients to audiology, stigma related to the term dementia, importance of patient autonomy and agency, multi-agency service provision and linking them with cognitive impairment, and the need for education and training. Report findings and recommendations. This report has been a scoping exercise to establish baseline numbers and future projections that would enable future planning for local authority and national level. To supplement this data, it's also been possible to gather some initial views on current provision from members of the audiology profession. Further qualitative research in this respect would be beneficial. In 2014, Wright et al. Carried out a UK-wide exploratory survey of the audiology profession. In this, the researchers defined their work as one of the first papers to explore audiologists' views and experiences of working with people with dementia. They argued that their study brought to the fore interesting points worthy of further research using both quantitative and qualitative methods. This has also been true for their study. Further qualitative research, moreover, involving people with dementia and their carers is essential to inform service planning. As Murphy argues, it is essential to understand the experience of living with dementia from the perspective of people with dementia so that services can be appropriately constructed. In addition, both current and future research proposals highlight the importance of understanding the link between hearing loss, social isolation, and how this influences cognitive decline in dementia in older adults. Social isolation was identified as a possible later life modifying factor for dementia, and as such, establishing the connection with hearing loss has the potential to positively impact 2 of the 9 factors. It is important to consider deafness within the spectrum of the 4 pillars discussed within this report, as although hearing loss has an overarching barrier to inclusion, each pillar has specific barriers that need to be highlighted and addressed in their own right. Overall, in terms of deafness and dementia prevalence in Scotland, there is no central data collection point. The data held by GPs is not as yet accessible by audiology services. Gaps in data recording ultimately result in underreporting and inevitable gaps in service provision for individuals with hearing loss and dementia. Moving forward, it's essential to address these gaps. Future research in the wider arena. Collaborative international studies ongoing at present are scheduled to be published in 2022. For example, researchers at Johns Hopkins University have launched a major randomised control trial which seeks to establish if treatment for hearing loss can actually prevent or slow down cognitive decline. The study will also investigate the impact of any treatment of hearing loss has upon loneliness and isolation. Furthermore, Dr. Piers Dawes will build on previous research at the University of Manchester in a project jointly funded by Alzheimer's Research UK and Action on Hearing Loss. As with the previous new project, results are due in 2022, and within this study, researchers will investigate if dementia is directly caused by hearing loss, if hearing loss is an indirect consequence of social isolation caused by hearing problems, or if there are other biological factors that increase the risk of both hearing loss and dementia. There is a shift in emphasis in terms of research questions as knowledge on hearing loss and dementia is documented. Research studies seek to shed light on the importance of preventing social isolation currently due to hearing loss and the impact this can have on dementia. In this regard, hearing loss is not only a potentially modifiable factor for dementia in its own right, but potentially has the strong link to one of the other factors listed by the Lancet Commission, namely social isolation. If the link between the two is further demonstrated, the importance of managing hearing loss in terms of managing dementia becomes apparent. The current UK-wide COVID-19 lockdown has brought the impact and understanding of social isolation into the mainstream, and the devastating effects that this isolation has on people with dementia has been openly discussed in the media. Those with hearing loss are at risk of increased social isolation. Those with hearing loss and dementia are doubly vulnerable, and the limited social interaction during lockdown increases the risk even further. In terms of summing up, there can be no doubt that COVID-19 pandemic has brought with it a unique chance for a greater understanding of social isolation that many with communication difficulties experience on a daily basis. It is essential to build on these new levels of awareness in society and use the momentum to bridge the gaps that exist in current service provision for those with hearing loss and dementia. I hope you've enjoyed the content of this presentation today. Please take a note of my contact details and don't hesitate to get in touch if you would like to clarify anything. Thank you for your interest. It's been great to tell you about the research journey so far. The last slide here, I've included the references that I've made mention to in the presentation. And also I've included downloading the report information, and my contact details are at the end. Thank you.
DataFakts, Actual Research, Social Science Insights.